Okay, next question. How high would you go on your insulin dosing for very insulin resistant patients?
As high as I can possibly get. Again, if I get over, if I'm giving a patient over 40 units of insulin, whether it be NPH or Humalog, I usually split it in half so that the patient ends up injecting that dose into two different sites. I've actually also used U500 insulin, which is highly concentrated insulin in our very insulin resistant type 2 diabetes patients who are overweight. And I've had good experience using that insulin.
Thank you. Does Lantus make more sense than INH, I think that's wrong, NPH, for women who go to bed early and have high fastings?
Yeah, it probably does. But again, remember, Lantus doesn't peak, so it's going to potentiate the dawn segment hypoglycemia, so just be careful with that.
Okay. Can you repeat the onset peak and useful life of metformin in pregnancy versus non-pregnancy?
Sure. Let me go back to that slide. And of note, I just recently read, hot off the presses, a new paper that doesn't demonstrate a difference between the metabolism of metformin in pregnancy and the peak of action of metformin in pregnancy and outside of pregnancy. So it seems to be about the same. So it peaks within 4 hours, and the plasma half-life is 2 to 5 hours.
Great, thank you. Do you have a minimum amount of carbohydrates that you like your GDM patients to have?
Minimum?
Mm-hmm.
Usually I tell them about 15 grams of carbohydrates with snacks. And I try to keep that minimum dose with meals as well, but generally speaking, I tell them no more than 30 milligrams, or 30, yeah.
Okay, thank you. Boy, okay. General testing of all women early in pregnancy, if they have severe NV, do you notice that their A1Cs might be higher in relation to the higher severity of NV? I try to guess who might get GDM in second trimester and wonder, as I think there might be a subgroup of normal women whose A1Cs go to 5.2 to 5.7 with hyperemesis. Does that make sense, or do you want me to read that again?
Can you read that again?
Yeah. Let's see. General testing of all women early in pregnancy. If they have severe NV, do you notice that their A1C might be higher in relation to the higher severity of NV? I try to guess who might get GDM in the second trimester and wonder there might be a subgroup of normal women whose A1Cs go 5.2 to 5.7 with hyperemesis.
No, I haven't seen that association actually. As you know, the California Diabetes and Pregnancy Program has recommended A1C and fasting plasma glucose in the first trimester, and we do that routinely here at UCSD, and we actually will be presenting data about outcomes associated with this type of screening in pregnancy at our Society of Maternal Fetal Medicine in 2014. But I have not seen that association. That's actually something interesting to look at.
Do you start with glyburide or insulin with elevated VGLs?
For gestational diabetes, I actually sit down with the patient and I go through the different options, glyburide, metformin, and insulin. I actually look at the patient characteristics. If their fasting plasma glucose values in the morning are very elevated and she's obese, I tend to have better experience with insulin in those patients. However, in most patients, I would say that either option is a very good option. I'm very honest with them and talk to them about the fact that metformin does cross the placenta, as does glyburide. And so I tell them that insulin does not cross the placenta, and sometimes that actually makes a difference for the patient. So I kind of give them autonomy to apply their treatment management.
Okay, thank you. According to the PDR, max dose of metformin is 2550. You mentioned 3000.
Yeah, outside of, and that is true in the PDR, that's what it says. And actually in the metformin trial by Dr. Rohan, they used no more than 2500 milligrams. And in pregnancy, that's what we use is no more than 2500 milligrams. What I put up in the slide is a slide of use in type 2 diabetes.
Okay, thank you. Do you prefer to use Lantus or Detamir insulin?
To be honest, I have not been using Detamir that often. In general, I have more experience with Lantus, so I tend to stick with this insulin. But again, I'm beginning to see more and more patients coming to us on Detamir, and I've had a little bit of experience, but I can't say too much experience with this insulin.
Okay, thank you. If you have a patient on glyburide who is going to start insulin, do you discontinue the glyburide or continue and change dose?
I usually continue the glyburide and add insulin. So I kind of tailor my treatment and the dose of insulin based on how much glyburide.
Okay, thank you. And last question. How long before meals do you recommend that patients take their metformin? How do you recommend QHS dose with snack at 10 to 12 a.m.?
So because of metformin doesn't really tend to have, I don't use metformin to target meals the way I do the glyburide. So, and because patients can have side effects with metformin, gastrointestinal issues, I tend to instruct patients to take the metformin with breakfast and with dinner to control their hyperglycemia. And generally, because of the high failure rate of metformin, I tend to use it in patients with very mild hyperglycemia. So those patients that have fasting anywhere from 92 to 95, and they're thin. Those are the patients I tend to use metformin in. And again, I don't dose it the same way that metformin is dosed, which is to target meals. I just use it in the right proportion with meals to try to decrease the side effects.
Thank you. Thank you so much. That is our last question.